Thank you. I'd like to call to order this meeting of the Quality and Patient Safety Committee of Cook County Health. And pursuant to the Illinois Open Meetings Act, meetings held remotely will require roll call votes for all action items. And in order to streamline the proceedings, we shall combine the action items into one combined motion so that only one roll call vote will be needed during the meeting. And meetings of the Cook County Health Board and its committees will be held remotely until otherwise noticed due to the determination that the public health emergency exists. And Madam Secretary, please would you call the roll?
Director Garza?
Present.
Director Kim?
Present.
Director Prendergast is absent. Director Story?
Present.
Chair Guggenheim?
Present.
And for the record, those directors also present. Director Ketting?
Present.
You have a quorum.
Thank you very much. And now I would like to invite our CEO, Israel Rocha, who is going to introduce the new Chief Quality Officer. Israel, yours.
Madam Chair, I don't believe he has joined us yet.
Oh, okay. So we'll proceed. And I have an announcement to make that Chair Taylor appointed Dr. Kim as a new member of the Quality and Patient Service Committee as of 2 days ago, I think. The next committee meeting of the Quality and Patient Safety Committee will be held on Friday, the 21st of October at 10:30 a.m. And is there any public testimony?
We did not receive any testimony.
Thank you. In that case, we'll proceed to item 3 on the agenda, which is the report on quality and patient safety matters.
And Madam Chair, Mr. Rocha has joined us.
Oh, okay. Israel, over to you to do the introduction.
Sure, we are very pleased to have joining us with us is our Chief Quality Officer, Dr. Eric Makaitis. He comes to us from the Franciscan system with a tremendous amount of experience in quality and quality programs. Can you hear me okay?
Yes, thank you.
Great. He was selected because of not just his experience in having run large complex systems, both at a regional level and a local hospital level, but in his interview and his discussion, his ability to want to create a just culture, but to aim for the highest standards in quality medicine, especially for patients who have been underrepresented in the healthcare system, the system at large, truly was what led to his selection. He has a true ability and a proven track record of helping to turn systems around to become high-performing systems and being able to reach the best practice models and methods and targets across the country. And truly his work and his expertise and his dedication to his field and his practice was what made him our choice to now introduce you as our Chief Quality Officer for the Cook County Health System. So with that, Dr. Makaitis, do you want to say a few words and to the Quality Committee?
Mr. Rocha, thank you so much for the very kind introduction. I very much look forward to working with you as the board and engaging with you on quality improvement efforts. Thank you all very much.
Well, let me add my welcome on behalf of the committee. We're very glad to have this slot filled, and we welcome you to these endeavors as we try to improve both quality and patient safety. So we wish you good luck in your quest.
Thank you very much, Madam.
Thank you. Now we'll go on to report on quality and patient safety matters, and Leslie Frayne, who's the Associate Chief Quality Officer, is going to review the HRO dashboard for us. Leslie, go ahead, please.
Good morning, everyone. Thank you, Chair Guggenheim. There's probably nobody happier than me that Dr. Makaitis is here as the new Chief Quality Officer. I have thoroughly enjoyed reporting here to the board members on the quality metrics. Since this is only week 2 for Dr. Makaitis, I agreed to go ahead and continue to do this for today. And then I will be passing the baton to him for our next QPS meeting. So thank you. So we have our 30-day readmission rate for Stroger Hospital. As you can see, there was actually a decrease from May of 10.5 to 7.49. I'm sorry, in April it was 10.5, going down to 7.49 in May, which is well below the target and stretch, the target of 9.93 and the stretch of 9.73. There was actually a decrease in the number of readmission of trauma patients from the previous month that was rather high, that contributed to this decrease amongst others. Of all of our service lines actually had a slight decrease in our readmission rate, our 7-day readmission rate, which contributed to this. As we all know, one low data point does not make a trend. So we're as happy as we are to see this low rate, sustainability is always key. So we'll keep our eye on this for the next month. And also our readmission by base MS-DRG of our index visit, which is our index visit is of why they came in. Those with the highest 30-day readmission rate in the rolling 12 months include cirrhosis, hematology patients, and digestive disorders. But for overall, for our calendar year 2022 through May, the 30-day unplanned all-cause readmission rate continues to average from this sawtooth pattern. Our average is about 10%, and actually our average has been about 10% since 2017. The readmission work group, we continue to focus our efforts on heart failure readmission, as you all know. Dr. Jabbar reports out here quarterly. And although there was a slight increase in our 30-day heart failure readmission rate, there was a decrease in our 7-day, which is good. And I think some of the tactics that they're working on in our readmission work group really are starting to have an effect, especially in that first 7-day period, which is our follow-up appointments. We're actually requesting these upon admission instead of waiting till a discharge at last minute, making sure those are happening. And also making more slots for the cardiologists to see these patients within 7 days. They're opening up more slots, and then we're actually monitoring how many patients actually show up to those visits. We're also doing pharmacist consultation, making calls post-discharge using 2 pharmacy students that are on rotation and rotating those students, and also using Tiger text in the communication process for when patients are ready to be discharged, between discharging nurse and pharmacy. And also our transition of care nurses, I think I reported last month, now have Tiger Connect, making it easier for patients to communicate with them. They're meeting with the patients and actually giving them their phone numbers to communicate with them on their index visit. So when they first come in, and then to call them first before going to the emergency room to hopefully avoid that ED visit if possible. And we have also, which is new, added 2 transition nurses to see COPD and asthma patients at the bedside and make those post-discharge phone calls. So we've been talking about expanding some of these initiatives from the heart failure population, and now we are starting to do that with the COPD and asthma patients. Next slide. This is our case mix index for our medical MS-DRG. This increased in May from 1.269 to 1.191, which is above target goal and just below the stretch, as you can see. The increase in that big spike in January, again, is from the large volume of COVID patients that we saw during that period. And as we all know, COVID increases your CMI by 20%. So, of course, good that our COVID patient population is going down, so you would expect to see your CMI also go down. The increase also aligned with an increase in our capture rate in medical DRGs between May and June. It went from 63 to 66%. And the next slide is our case mix index for our surgical cases. This decreased between May and June from 2.939 to 2.779, and we did not meet our target or stretch goals or outperform our busy benchmark for comparable hospitals, which is 3.060 for that benchmark. The capture rate for surgical DRGs increased from 64 to 66% in June. And as we know, we have our clinical documentation improvement team. We continue to target specific service lines, do education, working with improvement in our documentation to increase our CC and MCC capture rate, which of course then increases your CMI. Some of the data reported out by our CDI team that aligns with this June data was that we performed 97.5% concurrent review rate, which is very high. So they're seeing 97.5% of our patients. They did 178 physician queries, 95% response rate, 97% agreement rate with those queries. So there was an actual $676,000 financial impact to the CDI physician queries. Our next slide is our top box score, recommend the hospital. It's actually showed a slight decrease between June and July from 69 to 68. And actually we have Dr. O'Brien and Ling Dang. They're presenting today for the HRO Patient Experience Work Group, and they will be giving us an update on the tactics and improvements relating to patient experience. Our next slide is our HEDIS, hemoglobin A1C greater than 9 for our in-care population, which is 2 clinic visits within 2 years. This is a slide where we actually removed the out-of-network tab on this metric because it was just a little bit confusing. So we are now just reporting out on the patients that we actually see and can make an impact on. The goal is 24%, which reflects the top decile performance. And with our continued improvements, Stroger continues to close in on the top decile performance threshold. So we are actually exceeding the 90th percentile, which is 34.6 nationally. So we are exceeding that, which is good. The HEDIS group in our clinics, we call it the HEDIS Triad, which includes Dr. Irons, Beth Vaklovic, who is the ACNE, and Madi Ferreira, who's the Director of Quality for Ambulatory. They're continuing to work with the HEDIS groups and physicians and operational leads to continue the improvement process. The future state process maps of the 5 priority measures are actually now in the final stages of approval. A lot of great work going on there.
It looks as if we actually have a trend there, doesn't it?
Yes.
Which is very encouraging.
Right. 6 data points make a trend, so they say, and performance improvement. So we are just about there. So very good to see.
Carry on with the good work.
And the next slide is data definitions. I'd be happy to take any questions. Director Story.
Yes, I was listening, but I didn't grasp what you were saying with respect to the A1C scores. Were you changing the denominator, or I didn't hear exactly what
we got rid of some of the we were measuring in network, okay, which is in care, I should say, which is the patients that we see at least 2 clinic visits within 2 years. So we're actually seeing those patients. We can impact these patients and in the care that they're receiving. We had another line on here that was for out of network, which were for patients that are actually signed up through county care to be seen in our clinics. However, we're never being seen. So it's very hard to mix those numbers and understand those lines. So just to be a little bit clearer, these are just for the patients that we actually see and can be impactful on.
Yes, thank you.
You're welcome. Any other questions?
Okay, hearing none, would you proceed to give us the regulatory and accreditation update, Leslie?
Sure. So we have no follow-up for any current surveys. We have a lot of things pending. I think I've been reporting on these every month. We're still waiting on the same surveys. Our stroke certification survey window is open. We are actually having a second mock survey scheduled this month with our QHR consultants. And then we have our Provident Joint Commission extension surveys for our mobile MRI. We're waiting again on that. Mock survey scheduled again with QHR for October. That was rescheduled. And then our Belmont Cragen Health Center that opened. So they'll be coming back for a one-day unannounced on that. We did have a mock just on August 25th. The report was received and the leaders are working on all the action items for that Belmont Cragen. And then our Stroger Trauma Designation Survey. That date will be determined based on when we feel like we are ready to proceed with that. And then, of course, just our basic continued survey readiness.
Okay, thank you. And now we're going to have the update on the high reliability organization dyad on patient experience. So please go ahead.
Hi, good morning. Could you please, this is Lynn Dang, I'm the Chief Experience Officer. Dr. O'Brien had a family situation, so he won't be online today. And I'm not
No,
sure
I'm here. I'm
Oh,
sorry.
you are? Okay,
Ms. Dang,
sorry.
I'm here. Yeah.
Okay. Okay, could we go to the next slide, please? Oh, so Dr. O'Brien will speak on this.
Yeah. Give me 1 second, please.
Excuse me, I'm sorry. Dr. Story has his hand up.
Okay.
Hi, Dr. Story.
Yeah, it was about the regulatory update.
Oh.
I was just wondering if there was any concerns from the mock survey that was conducted on August 25th. I know that the team is working on the action plan for that. Just, is anything that you all would be willing to share at this time that would be helpful? That's all.
Thank you.
This is Leslie. Marty, I don't know if that's something that you'd be able to speak to because I know you have been working on that follow-up.
There's nothing.
The mock from Belmont Cragen.
Yeah.
The mock survey from QHR. Anything concerning?
No, I don't think so.
Basically,
Thank
low level concerns is what. They've been doing a lot of great work over there, getting that ready. Thank you for your question.
So, and thank you for your patience. So we'll get started with this. And so, just to remind everyone that the dyad, we have a number of dyads, and our dyad is around the patient experience. And our overall mission is really to improve a number of areas as they relate to our patients so that the patient feels that our system is a place of caring. People come in and feel cared for. And so we really kind of put that then into three areas. The most important one is communication. And the communication is every patient, every time. And so, one area that you'll see we've been focusing on is with nursing on the inpatient side. And the idea that at the beginning of every shift, the nurse will introduce themselves, what to expect, any pressing needs. Anytime we give a medication, we really want to make this part of the culture. What's the purpose of that medication and any common side effects? And then at the time of discharge, really helping the patient. And this integrates with a number of the other areas. If a patient understands their medications, understands the importance of taking them, understands any side effects, the compliance with those medications will be better and the readmission rate will be less. One of the other areas is when we don't do a good job is being proactive in our service recovery. This will, but by doing things like toileting, that actually proactive in that we don't have a fall and there's no service recovery needed in that case. It improves patients' perceptions of care when we are trying to anticipate or trying to prevent things. And then, of course, that improves our HCAP scores. And one of the other areas is quietness. And so we began a pilot quiet campaign on 6 East. It was very successful, and now we're really spreading that to the rest again of the inpatient side. And so these are one of the biggest measures, or the measure that we really put the most importance in, is the HCAP score about recommending the hospital. And you've seen a number of our HCAP scores, and this looks a little bit different, and it's a little bit different for a couple of reasons. One is we've changed the time frame that we're measuring our responses from our patients. So we're actually grouping the responses not by when we get them back, but by the date that they were discharged. And so you can see here that there's a little lag between in that last grouping from May through July 31st, because we're still getting some people responding that were discharged during that time period. And that's why we got a little drop off in the number of responses there. The other thing that you'll see is a little drop off in the likelihood to recommend the hospital. And so this is the top box score. And what we really want to see is the previous 2 quarters, we were seeing it progress upward. And we do believe that some of our interventions were responsible for that increase. But then we have a more difficult time explaining why it dropped off. As we'll talk about a little bit more today, again, these initiatives will be measured. The success of them will be measured by the likelihood to recommend the hospital.
I'd like to chime in. I'm sorry, real quickly.
Please.
There's a possibility of the likelihood to recommend the hospital dropped off during this particular quarter is because we also implemented the no visitor policy, and a lot of the patients were quite unhappy about that. And also, if you do a comparison, the percentage, what we call like the top box scores, that's what we are being graded by the patient. And then the number that you see underneath at the end where it's 69%, they're telling us that we are always providing, like they are always going to recommend the hospital. And the number 52, that's the percentile ranking. That's us being compared to other hospitals, meaning even if we had 90%, if the patient would recommend our hospital, but if 48% of other hospitals also get 90% or 98% of their patients would recommend their hospital, the ranking, the percentile or ranking would always be lower. But yes, for that quarter, it was because we had the no visitor policy, and we had a lot of complaints through patient relations concerning that. However, the good news is we did increase the visitor policy to 2 visitors per patient this last week. Next slide. And I'm always impressed by the communications about our medicine. Slowly we're going up. That seems like the trend, but I do know that our doctors and nurses are doing a great job at communicating the medicine. One of the initiatives that we are doing is providing a customized discharge folder, where inside that folder will also allow us the opportunity to discuss their medicine, and that will help improve our HCAP scores. Next slide. And also communications with doctors. we have our patient family advisory council meetings, and our patients are always saying how much they love our doctors and our nurses, especially the doctors. Right here, there's a small decline. However, we're working and monitoring that to continue to increase it. But from all of the hospitals I've worked at, Cook County scores has always been the highest I've ever seen compared to other hospitals I've worked at, and this is including Stanford Healthcare. So kudos to our doctors when they communicate to our patients, and I'm so proud of them because our patients truly love our doctors. Next slide.
And I'm just going to jump in here for 1 second, and I know that Commissioner Story has a hand up, but before we get to that, I just want to dovetail on what Ms. Dang is saying, and we do see a little drop off here in the last quarter, and I've been anxiously awaiting the next HCAHPS data, because in July we did something, and when I say we, it wasn't our dyad, but the hospital did something that we've been working on for over a year, and that's the way that we assign the patients and the doctors to the floor. So in the past, what would happen is patient would go into the next empty bed, and whatever doctor was up for that admission would take that patient. So the doctors would have patients on 9 different areas. And that meant that they were continually moving from unit to unit, and they were not available when a patient had a question or a nurse had a question, because they were on one of the other 8 units. Well, now what we've done is we've stationed the doctors with the nurses on one floor, and the doctor receives an admission when a patient is admitted to their unit. And so the doctor, the nurse, and the patient are all there all day, all the time. And so I was on in July after this change was made, and it was fantastic. The nurses were asking me questions because I was sitting outside the room, and I was going back into the room because I was on that floor. And I really expect that to show in patient satisfaction. And I'm sorry, so Commissioner Story, please, your question, please. And you're muted, sir. Commissioner, I think you're muted.
Thank you for taking my question. My question is, first, the latter part of your comments about the changes that you're making with respect to the physicians and proximity to patients that are being admitted to a service. Are you saying that we're going to have bed assignments by clinical disease as opposed to a scattered bed concept?
Yes, that's an additional thing. I didn't get into that, but yes, we have designated several of our units. For instance, there's an oncology unit now where the nurses on that unit have expertise in taking care of cancer patients. The doctors on that unit are there taking care of the cancer patients. And so, yes, that's part of it. We're going to have a cardiology unit, and there's a renal unit that's going, and a neurology unit that are in the offing.
I think that's a great move on your part to move away from.
Yes, and I can't take any credit. This is Dr. Kamapli and Dr. Pirko and a number of the other leaders. I simply am very excited about it.
Well, I'll give the credit then to the entire team at CCH.
Okay, well, thank you.
The second question is, can you comment on the sample size?
Yeah, so what we were saying here is that the sample size is only 226 for this last quarter. We do expect that to go up because there's now a lag. We're looking at discharge at the date the patient was discharged. Whereas before, what we were doing is we were taking any responses that we had that came in between, in this case, February and April, regardless of what month they were here in the hospital. We reported the data by when we received their response. So you'll see here that the 226, I expect that to go up, but it's already higher than the sample size we had in between November and January. And I cannot comment on why that first sample size of is only 86 back in the pandemic. I can't believe that that our volume was that low. But the other part of that, and one of the other initiatives, again, not from the patient relations diet, but overall from the hospital, is to try and increase the sample size, because as I'm sure you know, whenever you do surveys, the people in the middle are the people who, if you can get them to respond, you're going to get some very valuable information. That the people that are very happy and the people that are very unhappy are oftentimes the most likely to respond. And we, by increasing our sample size, we think that we'll actually improve our scores.
Is there any particular number that you're shooting for that would be what you would consider an appropriate sample size going forward?
So currently we are very low compared to the national average. We are hitting about 9% to 12% of response rate, and the national response rate, average response rate, is about 27%. So we're hoping to maybe move up to 27%, if not higher. We're doing a lot of different initiatives where we are also handing out flyers to remind the patients, all new patients, to fill out the patient satisfaction survey, as well as notifying them on the My Portal. And then also with this new discharge folder, we're having that flyer inside the discharge folder as well. So, but our goal is to hit at least the national average at 27%.
Have you all put a
And the
target? I'm sorry, Dr. Brown, go ahead.
No. It was Israel. Go ahead, Dr. Starr. I'm sorry, Lynn. When you're finished, I have one comment about the new measuring methodology and why it's more helpful. So please go ahead.
No, I'll listen to you because Israel, that was my question in terms of a go forward strategy. So thank you for jumping in.
Sure. No, the real reason that we think this will be particularly helpful is that by really segmenting the different surveys for the time period that they were actually in care, it gives us a better way to really track what improvements we're doing and to see the improvement or lack of improvement when we are able to do quality initiatives. And so that's really what I want to commend the team for moving to this type of measurement, because if we really wanted to know if we did something different in this quarter and there wasn't an improvement or there was a reduction, we can go back and triage as to what we were doing differently. If something changed, as Lynn talked about, we didn't have patient visitation during this time. It really lets us look at how we can hone our services better for our patients. Before, when they're blended, it was sort of hard. You were doing best guess. This is a much more precise instrument to know what exactly patients are saying during a particular period of time. And that really will help us hear the voice of the patient better related to the improvement initiatives that we have going forward. Also, we hope that when we're improving our services, our sample size will get a little bit better. What most people understand is that you really get the largest amount of surveys from two groups of people who are very, very, very happy with your service and want to tell you how pleased they are with their service, or people who are very displeased with your service and want to give you the information for the opportunity to improve. Those are usually the most engaged respondents. And then you have some in the middle that also want to be able to give a particular type of comment. So we're hoping that as we continue to improve our services and our patients want to continue to give us our improvement, we can get there. Our first this milestone goal, and we'll work with Lynn, is to try to increase our improvement rate. As she said, we're at about, we want to go up from where we are about 10 to 15% from the current mark that we're at. but we hope that as we continue to improve those services, like we do geographic localization, clinical specialization, and we start to do other initiatives like the patient folder. We're also doing a patient comfort kit that's going to be going forward, and many other things we're doing to improve our both clinical and our comfort settings, that will get more people willing to write back and tell us what they thought about what we're doing.
Thank you.
Thank you.
So we'll go to the next slide, please. And then next slide, there we go. So Lynn, I'll turn it back over to you.
All right, thank you. So one of the other initiatives that we are hoping to improve our HCAP scores and also to decrease our complaints is rolling out the standards of behavior, the CI care model. Think of it as C, I care. This is just step-by-step action for our staff members, our clinicians, just everyone to be able to follow in how we interact with our patients and with our colleagues. So C, each letter has an action that you have to take, and as you can see, I don't need to read through this, but we have gone through our train the trainer about a month ago, and we just need to have more trainers in order to start implementing it. Our goal is actually to be able to train all of our staff members 100% within 1 year. There are certain goals. At first quarter, we would hit 25%, second quarter, 50, and then 75, and then 100. Next slide, please. And this is the sample of our Quiet Pack welcome kit. We have piloted this about a month ago. We look at the census to see all the new patients. We would visit the patients and then introduce ourselves as patient experience, thanking them for choosing Cook County and letting them know that we are here to support them. And if they had any questions or concerns, we could help them right there and then. And inside the Quiet Pack, it has the earplugs, the eye mask, lip balm, and some books to keep the patients occupied, as well as helping them to remember the questions that they have for their care team. So far, we have been able to meet about 12 to 19 new patients a day. Since it's only been piloted a month, we're still waiting to see how it got affected in the Press-Ganey HCAP scores. Next slide. This is also an example of our script that we use when we meet with our patients using the CI care model. Next slide. Does anyone have any questions before Dr. Whitten shares? Thank you.
Okay, thank you, Lynn. Thank you, everyone, for this opportunity. I'd first like to start off with sharing a positive story. Jeff Doucette, those of you that do not know him, he's a CNO that's worked for Press-Ganey for 2 years. We were blessed to have him on our site yesterday. The reason why I want to start off with this story is to let you know he came in early, stood in our main lobby. We weren't aware of this. And he sat there and watched as our patients came to the hospital and how they were addressed. He managed them up. He managed our security team, our environmental service. He rounded in our emergency department and inpatient. I just want everybody to know that it is hard to impress the CNO of Press-Ganey when he goes to many organizations. But when he debriefed, he compared us with Henry Ford that he just went to last week, UCLA the week before in Grady Hospital. And what impressed him was we had our emergency room was filled with patients, and he walked through all the areas and did not feel that it was chaotic. That says a lot. Even when we rounded on the patients were able to tell him what they appreciated at this organization. So I just wanted to start off and say kudos to Cook County Hospital, our Stroger system, and everyone, because we appreciate the leadership support top down that's helping us to focus more so on this patient experience. So what I would like to show is this. This shows us that changing the patient experience culture is going to take a village, and I appreciate all the village. This is just a quarter of work that's done. We're going to take a village team of support for the improvement that's being done. I want to share with you, here are some of the things that have been done. We are totally supported with leadership rounding. Our goal is to be consistent with this and around the clock. I will share with you some of the things that we're going to do in the future, but we're excited. It's hard to get these increases, but we're showing an increase, as you can see here, for second quarter. Once the third quarter is over, we will update each slide that I'm going to show you. But in showing you the slides with communication with nurses, here are some of the things that are helping to drive this score. Staff has been trained on purposeful rounding. We will continue to do that with our patients because it's important. Thank you, Lynn, for bringing eye care here, because CI care is going to help us lead this to even higher patient satisfaction scores. We have early service rounding recovery that's being done. We're hardwiring our bedside shift report, and we're also making sure that in the huddles that we keep information. Our future plan is, thank you, Dr. Peters, we've approved for even more support and Dr. Kamoply's positions to help us with all shifts. And what we're doing, Dr. Brian, Lynn, and I at the table, I implemented the diet model back, and we appreciate each position connecting with the manager of every unit to own safety, quality, and service. We also have interdisciplinary rounds that make a difference, knowing the patient plan of care, nurses going back to the room, keeping the patients informed, saying the same thing that the physicians are saying, so we can stay on the same accord. And earlier, Dr. O'Brien spoke about our geographical localization, which is very helpful, because when you have a stroke unit, an oncology unit, specialty units, nurses become the expertise and they're able to build dynamic relationships with their physicians. So there's a lot of positive things that we're working on. Our future is we want to be consistent around the clock and hardwire this process, because the hospital operations is 24/7, including the weekends. Can we go to the next slide? The next slides will show you, yes, these are small increases in percentages, but they're huge when they come to the Press-Ganey playbook. Huge enough that Press-Ganey reached out to us and asked us, what did you do during these quarters? Because post-pandemic, most hospitals are dropping, whereas you're increasing. So our challenge is going to be in transparency. We are going to still keep increasing in evaluating and analyzing our information. So nurses explain in a way that you understand. We're working with each nurse and our nurses and huddles to make sure that they stay in front of the patient and the family, because the family is our customers too, and that we speak to them in a way that they understand, especially when it comes to the medication. Next slide, please. Again, you'll see another increase. Nurses listen to you carefully. We are really focusing on professionalism here in the organization, looking at our highs, solids, and lows, and having everyone measure up, because again, this is around the clock. So more work to come, and we'll be glad to come back. We're looking at the more updated data once we close out our third quarter. Next slide. And nurses treat you with courtesy and respect is dear to my heart. We come here, the patients choose here, they could go anywhere. So it's important that CI care is implemented and that we breathe this every day. So these are just some of the things shortly that we're working on, and we'll have more to come. Thank you. If there's any other questions.
And before we take questions, I just want to point out here one other thing that's quite impressive to me. Nurses treating with courtesy and respect. The score that we have for the first quarter for quarter two of 2022 is not only the highest score that we've ever had, and that's going back for 4 years, but it's double the closest score to it. So what we're seeing here is that this is really paying dividends and taking off. And so we're very excited to continue to get data.
There's a hand up. I don't know who it is.
Hi, this is Marty. It's not regarding Press-Ganey. I just wanted to go back to Mr. Story's question. Does anybody else have questions for Press-Ganey before I go? Regarding the August mock survey for Belmont Cragen, there were a total of 21 findings, and 5 were high risk related to infection control. They had to do with sterile equipment supplies and AED training, which we have addressed. There was about 15 moderate risk that had to do with a hopper faucet leak, a light covered with plastic, shipping boxes, and exam gloves without expiration dates. And then there was one low risk that had to do with safety data sheets available for environmental services. That's it. Thank you.
Thank you for that update. I appreciate that. And in essence, it speaks to the reason why we have the mock surveys. Thank you. That's great feedback. And I'm sure the staff appreciates the work that QHR is doing with them. So that's good news.
Thank you.
Chair Guggenheim? I think you're muted.
Sorry, I couldn't find the right button on my computer. Well, thank you all for those reports and the answers to the questions. So we'll now move on to item 4 on the agenda, which is action items. And under the first heading, we do not have any recommendations this month for appointments or reappointments for the department and division chairs at Stroger Hospital. So we'll move on to the second item, and Dr. Akintorin is going to present the Stroger Hospital medical staff action items for the committee's consideration, and he will also summarize the quality committee actions for the committee's information. So Dr. Akintorin, over to you.
Yeah, thank you, Madam Chair. Good morning, Director. I am presenting the EMS committee of John A. Stroger Junior Hospital of Cook County approved list of medical staff action items. These are the list of medical staff appointments, reappointments, and changes. This was approved at the September 14th by the Executive Medical Staff, and I'm presenting that for your consideration. Thank you. So I will now go to the summary of the HQPS committee report for September. And of course, this is based on the meeting of July 26, 2022. The EMS has the minutes already, and has already taken that into account. So the highlights from July, the HR domain, we have clinical documentation, the surgical MSDRG case mix index increased from 2.82 in March to 3.274 in April. This was accomplished by the increased capture of procedure codes per patient. There was also a higher acuity of patients in April. I would just like to add that clinical documentation is an area where the medical staff is focusing on to up our game there, because that is very, very important. And you'll be hearing more about this in the days ahead. Environment of care for both months of May and June 2022, staff were 100% compliant in wearing N95 masks correctly. For the second quarter, staff were 100% compliant in knowledge of the different code colors, what to do in the code pink, and how to appropriately request police / security in an emergency. Radiology, Structured reporting is being implemented for multi-parametric prostate MRI and the assignment of assessment categories. Q1 of this year shows 100% compliance with 32 out of 32 cases documenting using structured reporting. And lastly, the second quarter also shows 100% compliance with 38 of 38 cases using structural reporting. There were no action items presented for the EMS committee, and I do not have any action items to put before you this morning. Madam Chair and directors, if you will permit me to just put a quick remark here about the presentation that you had from Dr. Dang and Dr. O'Brien, which continues to report the excellent work that my colleagues, medical staff that I represent, are doing in the area of communication. That even the rating, the score is higher than what is happening at Stanford. The medical staff is committed to even improving on this, and of course on many other areas. And we show our readiness to do whatever we are called upon to do, and even beyond, to continue to deliver excellent care to our patients. And I would respectfully ask you to remember that, especially when we come back to you in the future for maybe some asks. Okay, so thank you very much.
Thank you very much, Dr. Akintorand. Okay, noted. Do we have somebody, Madam Secretary, to report from Provident today or not?
Well, Dr. Kirby did not let me know in advance that he wasn't going to attend, so I'm wondering if he got pulled away for patient care.
Yes, it seems as if he has a sort of continuing conflict, I think, doesn't he, with his clinical duties on this time slot. So we don't have anybody from Provident today?
I do not believe so. The committee received the Provident quality summary in advance and the medical staff actions also in advance.
Right, so you have had those for reference, committee members. And the final item is the minutes of the August meeting, which are presented for the committee's review and discussion if that's necessary, although they have already been approved by the board at its August meeting. So any corrections anybody has of the last month's minutes? If not, and hearing none at this point, I would ask for someone to move the following combined motion to approve item 4B, Stroger Hospital medical staff appointments, reappointments and changes, to approve item 4B, Provident Hospital medical staff appointments, reappointments and changes, and to accept the August 18th Quality and Patient Safety Committee meeting minutes. Does anybody want?
So moved, Madam Chairman. So
Thanks.
moved.
And is there a second?
Garza.
Yes, we have a second. So please, would you call the roll, Madam Secretary?
Roll call vote on the combined motion. Aye or nay, Director Garza?
Aye.
Director Kim?
Aye.
Director Prendergast is absent. Director Story?
Aye.
And Chair Guggenheim?
Aye.
That's 4 yeas and 1 absent.
In that case, the motion carries. And I would now like to ask for a motion to go into the closed meeting, since we're going to receive some information on the quarterly patient safety report, which is subject to the Open Meetings Act exclusion. So we have, I'd like to have a motion to go into closed meeting pursuant to the following exception to the Open Meetings Act 52 ILCS 120/2C 111, 12, and 17. Do I have a motion?
This is Garza. I'll make the motion.
Thank
Second.
you. And it's been seconded. And so Debbie, would you call the roll?
Roll call vote on the motion to go into closed session. Aye or nay, Director Garza?
Aye.
Director Kim?
Aye.
Director Prendergast is absent. Director Story?
Aye.
And Chair Guggenheim.
Aye.
That's 4 yeas and 1 absent.
Thank you. See you all soon. Thank you.